Okay, I thought lesser content will make lesser parts of videos, but then my energy played a role and made the video shorter and requiring many parts. Anyway, so the first topic in this part 2.3 is most common cardiac murmurs. So we are going to separate it as systolic and diastolic. So what murmurs, most common murmurs you hear in systolic is? So most common systolic murmurs happens in aortic stenosis, mitral regurgitation, hypertrophic cardiomyopathy, mitral valve prolapse, atrial septal defect. So all these things we have studied earlier. We are just looking only at the murmurs in all these conditions, maybe comparing between all the murmurs to remember it better. And I think I also want to make a video with all the valve disorders, which will help me put together everything, compare and remember easily. However, anyway, so the most common cardiac murmurs are systolic. Most common systolic murmurs, first one is aortic stenosis. We just studied it in the last part. Like it has a crescendo descendo murmur at right upper sternal border. It occurs in mid to late crescendo decrescendo systolic murmur in severe cases, and in mild to moderate cases you hear it early, and it is heard in the right upper sternal border. It's not covered, so anyway. And also you hear soft and single S2 is also something we studied in the previous part. And the next one is mitral regurgitation. So in mitral regurgitation, you hear hollow systolic murmur at the apex of the heart and it radiates to axilla. In mitral regurgitation, you hear hollow systolic murmur at the apex of heart and it radiates to axilla. So what happens in mitral regurgitation? During the systole, the valves are supposed to be, the mitral and tricuspid valves are supposed to be closed and the ventricle is contracting, but as there is a regurgitation, you hear hollow systolic murmur throughout the systole at the apex of the heart. And during diastole, anyway, the valves are open and the pressure in the left atrium is high, so the pressure in the ventricles are low, so it just flows down, so we don't hear anything during diastolic, is what I'm thinking. And in hypertrophic cardiomyopathy, crescendo decrescendo murmur at mid left sternal border. This is due to the left ventricular outlet obstruction. When the ventricles contract and the septum goes close to the valve and the blood cannot enter in, so the blood cannot exit through the left ventricle outflow tract. This causes the crescendo decrescendo murmur at mid left sternal border. It is here at mid left sternal border. And the next one is mitral valve prolapse, that we just studied in the last part. You hear a mid systolic click followed by late systolic murmur. Mid systolic click followed by late systolic murmur. So why this click happens is the mitral valve prolapse into the atrium and the cardia tendinae just pulls it after it has prolapsed so back ballooned into the atrium, so it pulls it, and that is what we hear as a mid systolic click followed by a systolic murmur, because the valve is not so well closed or stable. And this end systolic murmur is probably due to the regurgitation in the late systole. And during atrial septal defect, we hear mid-systolic crescendo decrescendo murmur. So during the systole, what happens is the ventricles are contracting and the atrium is being filled with blood and there is a septal defect. So this causes the mid-systolic murmur. And also we just studied it causes wide and fixed S2. how the wide and fixed split S2, we just studied that. So the P2 is much later than the A2 due to left to right shunt. Right ventricle always have more blood, so P2 is delayed than normal both during inspiration and expiration. So why the wide and fixed split S2 is left to right shunt? Right ventricle has more blood. The murmur is from more blood through the pulmonary valve, not from the ASD itself. I don't know, I just what I just said, but yeah, there is a atrial septal defect and the atrium has more blood to drain into left ventricle, and the there is a left to right shunt and the right atrium has more blood to drain into left ventricle, and this murmur is not from the septum itself but the more blood going into the pulmonary artery because of a lot of blood in ventricle. So that's why we hear the murmur during the systole, and it is not from the septal defect itself, it is from the more blood going into the pulmonary artery. And why mid-systole is that when the systole starts, the pressure isn't that much, but once the pressure is once it goes into mid-systole, the pressure has built up enough to cause the murmur. And in ventricular septal defect, we hear a hollow systolic murmur at left sternal border. The ventricle septum is defective, so we hear the murmur during when it contracts. And the diastolic murmur. So the three diastolic murmurs are aortic regurgitation, mitral stenosis, and continuous the two diastolic murmurs most common are aortic regurgitation and mitral stenosis. And the next one is mitral stenosis. This starts as mid diastole, and as the mitral stenosis becomes severe, this also becomes this is also here at early diastole. So there are three things you hear during the auscultation in the mitral stenosis. There is an opening snap followed by mid-diastolic rumble with pre-systolic accentuation. So why the opening snap is here is right during the early diastole, so right after right in the beginning of the early diastole, the mitral valve is forced open. This causes the opening snap sound. And the pre-systolic accentuation is due to the atrial contraction and the atrium trying to push the final blood into the fully filled ventricle, and this causes the pre-systolic accentuation just before the start of systole. And continuous murmur throughout the systole and diastole is seen in patent ductus arteriosus. There is a machine-like murmur you hear at the back between the scapulas posteriorly. And the next topic is acute pericarditis with systemic lupus erythematosus. And I think the question had all presentations of systemic lupus erythematosus, and the options were like about the cardiac things. I don't remember the exact question, and also we studied acute pericarditis in part 1. I'm just gonna go over the things which we did not study in part 1. So in pericarditis, you hear pericardial friction rub, which is like most important clue we can find in the question. It can be in the question I studied, it was worded as scratchy sound between S1 and S2. And also SLE, the most common cardiac presentation in SLE patients are acute pericarditis. And yeah, the typical features are pleuritic chest pain that radiates posteriorly to the bilateral trapezius ridges. So this pleuritic chest pain radiates to the bilateral trapezius ridges. This is something we did not study in part 1. And Yeah, so the ECG shows diffuse ST elevation with diffuse T wave inversion, which we studied in the part 1, atrioventricular block. And echo shows pericardial effusion. Often appears, echo has a pericardial effusion often, but is very small in SLE. The treatment is NSAID, non-steroidal anti-inflammatory drugs, colchicine, but it is rarely used, and corticosteroids like prednisolone is used if the NSAIDs are contraindicated, and if patient has renal insufficiency, or if the NSAIDs are not working. And one another option I had in the question was costochondritis, and the question one another option I had was costochondritis, and the question in the question it was specifically mentioned that chest pain was not reproducible during palpitations. So where we can see reproducible chest pain with palpitations is costochondritis. The other option I had in this acute pericarditis with SLE question was varicose limb and sacs endocarditis. This is a deposition of sterile vegetation on the cardiac valves. It can also occur, the sterile vegetations can be immune complexes or thrombus. This is most common in SLE, and it is also common in primary malignancies. And the patients are usually asymptomatic, but they can have symptoms of systemic embolization like focal weakness due to stroke. These symptoms can present with limb and sac endocarditis. And the next one is treatment of acute aortic dissection. In the previous parts, we studied in detail about aortic dissection, but I don't know how I didn't get curious and see what is the treatment for acute aortic dissection. So for the acute tearing chest pain, you control the pain first. So you can give morphine, and IV blockers like esmolol, labetalol, propranolol is also given with sodium nitroprusside if the systolic BP is more than 120 mmHg, and emergency surgical repair for if the aortic dissection is an ascending aorta. And goals of initial treatment is pain control, reduction of systolic BP to 100 to 120 mmHg, and decrease in left ventricle contractility to reduce aortic valve stress. So that's why we use the IV beta blockers, esmolol, labetalol, and propranolol, because they reduce the cardiac contractility. One another thing we may use in aortic dissection is furosemide therapy. If the dissection is in the aortic root, the dissection involves the aortic root, which can lead to acute aortic regurgitation and then pulmonary edema. So we use furosemide therapy. The other options I had in this treatment of acute aortic stenosis question was hydralazine and nitroprusside. So maybe the question was, what would you use in this case of aortic dissection? And hydralazine and nitroprusside are vasodilators used in hypertension emergency, but they can cause sympathetic reflex and cause increased contractility. So they are only used if the beta blockers are not reducing the blood pressure. And by increasing the contractility, it also increases the aortic wall stress. So that's why it is used cautiously. Which one? Nitroprusside and hydralazine, and they are vasodilators. And no tissue plasminogen activator or anticoagulant are used because the risk of bleeding and propagation of blood to the pericardial space. Anticoagulation and no tissue plasminogen activator and anticoagulants are not used due to risk of bleeding into the pericardial sac. And I have also noted down here, it is very, very, very important to memorize hemodynamics of shock, different kinds of shock, because I saw multiple questions with this hemodynamic shock involving different types of shock. So the hemodynamics of shock is very, very important to memorize, if possible, with explanation, making sense out of everything. And this question, where a patient received some abdominal surgery, and during the surgery he required some blood transfusion, and he developed MI after a few days. and the question was MI and then cardiogenic shock. He was in cardiogenic shock. The parameters in the question was suggesting cardiogenic shock, but what could have happened is cardiogenic shock due to myocardial infarction. The options had a myocardial infarction. What is going on with the patient? So this MI after surgery is common when a patient requires blood transfusion during the surgery. This could be due to the decreased O2 delivery to the myocardium when they are hypovolemic, and no chest pain as they are on medication. So that is the key feature. They don't have any chest pain during this MI because they are receiving pain medications for their post-surgical pain. And yeah, if the patient develops fever, hypotension, and non-cardiogenic pulmonary edema within 6 hours of transfusion, that is called transfusion-related acute lung injury. So if the patient develops fever, hypotension, pulmonary edema, non-cardiogenic pulmonary edema within 6 hours of transfusion, that is called TRALI, transfusion-related acute lung injury. The next topic is ankle brachial index. So it is used in peripheral arterial disease, which we studied in part 1. And this ankle brachial index is nothing but ratio of systolic BP in ankle to systolic BP in arm. This is useful in confirmation of peripheral arterial disease. And if the peripheral arterial disease is acute, we don't go and take time to check the ankle brachial index, but it is measured only after anticoagulation IV. The other management options and investigate what we should do next, options were transthoracic. Not the options, in the explanation, maybe I studied that in the explanation. So we used transthoracic echo, TTE, to figure out the source of thrombus, if it's from thrombus from atrial fibrillation, atrial thrombus from atrial fibrillation. And CT angio is used to determine the location of arterial occlusion, and surgical bypass grafting is done in chronic PAD after managing the IV, managing the acute PAD by IV anticoagulant infusion. We just didn't know anticoagulation in aortic dissection. No. And the next one is mitral stenosis can cause thromboembolic stroke in the setting of atrial fibrillation from mitral stenosis is something we want to remember. Mitral stenosis can cause thromboembolic stroke. How? The left atrial pressure is elevated. There is a dilation of left atrium. This causes stasis of blood, and we know, we know from Virchow's triad that what are the things that can cause clot formation. Those are stasis, endothelial injury, hypercoagulability. So there is stasis, and this causes the embolus, and this causes thromboembolic stroke through mitral stenosis, because of mitral stenosis. So the question had features of left hemiparesis, and it was due to mitral stenosis. Mitral stenosis is something I studied in part 1, but however, it did not occur to my mind this could be a case of mitral stenosis. So I'm gonna recap this again. The etiology of mitral stenosis can be rheumatic heart disease in most cases, age-related calcification, radiation-induced. The clinical presentation is exertional dyspnea, orthopnea, shortness of breath when the patient is lying flat, paroxysmal nocturnal dyspnea. There could be pulmonary edema, or there could not be, and hemoptysis, afibrillation. There could be plus or minus right side heart failure, and if there is right-sided heart failure, you can see lower extremity edema, and increased risk for embolization. Actually, the question had features of stroke, but we have to think about the cause and then that as the clue for the answer. It's like going a quest on finding some treasure. And the diagnosis of mitral snap is on auscultation. You hear the opening snap and all those things we studied in the cardiac murmurs just now, with a mid-systolic murmur at the apex. And echo shows increased transmitral flow velocity, because as the mitral valve is stenotic, the velocity needs to be higher for the blood to go through. And the treatment is percutaneous valvotomy or surgical repair replacement. This is most common in young patients from developing countries. Long-standing mitral stenosis can lead to left atrial pressure that is evidenced by palpitation and irregular heartbeat, and the risk of left atrial thrombus formation. And RHD, mostly rheumatic heart disease, mostly causes mitral valve stenosis and rarely causes aortic stenosis. And the key features of rheumatic heart disease by mitral stenosis by rheumatic heart disease, the key features are hemoptysis, because I just couldn't relate hemoptysis with this, afibrillation, and cardioembolic stroke. And indications for statin therapy we already studied. So the next one is PDA dependent congenital heart diseases. Patent ductus arteriosus, when it needs to be keep opened if there are these conditions. Coarctation of aorta, there is a constriction in the aorta, and transposition of the great arteries. Hypoplastic left heart syndrome, the left heart is not functioning properly, so you need the PDA to be patent. And total anomalous pulmonary venous connection, and tricuspid atresia. Tricuspid atresia is something the tricuspid valve is totally absent, and you have no connection with no blood flowing from right atrium to the right ventricle. And prostaglandin E1, it is a vasodilator. We have studied it multiple times in the previous parts. Can be used even after the ductus arteriosus closure, because it can re-establish the connection, and it can be given even before the diagnosis is made. If the diagnosis of any of these 5 things are not made, you can still start the patient on prostaglandin E1. And the other options I had in the question was indomethacin. It is used in patent ductus arteriosus to close, the opposite of what we studied now. So it inhibits prostaglandin formation and facilitates closure of PDA. If the PDA is not closed, then there is going to be a left to right shunt, which is going to cause pulmonary hypertension, and then heart failure. The differential diagnosis for if the patient had the infant has cyanosis, the differential diagnosis for this cyanosis, apart from these conditions where the infant is not receiving enough oxygenated blood, is polycythemia. That can also cause cyanosis and hypoxia, and it is diagnosed by increased hematocrit value. Treatment is partial exchange transfusion. The other option I had was sildenafil. Sildenafil is a pulmonary vasodilator. This is used in treatment of persistent pulmonary hypertension in newborn. We also saw that we used nitric oxide inhalation for persistent pulmonary hypertension, right? And the other option I had was surfactant. Surfactant is a treatment for severe respiratory distress syndrome. The classical finding in X-ray is ground glass opacity, where you can see through the bones and can see the vessels. It is more common in preterm infants, and the surfactant is used for the severe respiratory distress syndrome.